Good morning. Welcome to the 24th Fall Psychiatric Symposium. My name is Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee. And on behalf of the MHA, our wonderful board and fabulous staff, welcome to the final day of the Fall Psychiatric Symposium. So those that weren't here yesterday need to give you the history, if you don't mind. 24 years ago, a bunch of dreamers sat in the room and said, why don't we do a small training event? Well, little did we know it would become one of the largest multidisciplinary psychiatric training events in the South, if not the country. So thank you all very much. We could not be nearly as successful without you here attending the symposium as so many of you have done over the years. So thank you very much. The symposium is a success because of not only our attendees, but because of our fabulous accreditors, as well as our sponsors. So let me share with you about our partners here. The symposium is accredited by the University of Tennessee Graduate School of Medicine, the University of Tennessee College of Nursing, the National Association of Social Workers, the Tennessee chapter, the Knox Area Psychological Association, and Tennessee Department of Mental Health and Substance Abuse Services. And of course, the event is successful because of the very generous sponsorship support and exhibitors that are partaking the event again this year. So we're very grateful for them. The symposium has a virtual exhibit hall, which, fun fact for the day, it's the same virtual exhibit hall that the NFL uses. So we felt really good that it was the right thing to have for our partners, as well as for the attendees to be able to enjoy. So our sponsors include the Tennessee Department of Mental Health and Substance Abuse Services, United Healthcare, Recovery Strategies, Johnson & Johnson Janssen, Cornerstone of Recovery, who has merged with Bradford Health, Focus Treatment Centers, and Focus Integrative Treatment Centers, Cumberland Heights, Pasadena Villa, The Middle Path, Village Behavioral Health, UT College of Social Work, and Genoa Healthcare. Now, to access the virtual exhibit hall today, to be able to enjoy the many offerings from our sponsors and vendors, just click on that tab at the top of the symposium conference platform screen that says virtual exhibit hall. Click on that, be able to access the exhibit hall, be able to sign in for any of the amazing door prize offerings or giveaways. Who knows, you could be the lucky winner of a big screen TV right before the holidays, or a rocking chair for your she shed or man cave, even a grill, so you can do some cooking out on the back deck, that sort of thing. Lots of great giveaways, and the partners want to get to know you and establish referral relationships, that sort of thing with you. So please visit. You'll have access to that exhibit hall through December 1st, which is fantastic. Now, about CE, the event is accredited, as I said, and our accrediting partners want to know, okay, Ben, how are you going to prove these folks were actually there? So this is how we prove it. When you're watching the symposium today, the platform is capturing your Zoom screen name. So if it's your professional name, you don't have a worry in the world. We're going to know you were there. We're going to know the exact duration you were there for each session you logged into. Easy peasy. But if you're like Cliff Dennison and you have a funny screen name that says Fuzzy Bunny MD, well, we're not going to know who that is. So we need you to tell us if you've got a screen name that's not your professional name. Just email us at info@mhaet.com. And that way we'll be able to marry up who the attendees are on the list of folks that attended that we get, and we'll be able to know you were there and for how long you were there. If we don't have your professional name, identified, but we have a funny name like Fuzzy Bunny MD, then we're going to have a hard time figuring out who was there and get you the CE. So please take care of that. So certificates for attending the event will be compiled after Thanksgiving and then emailed to you. If you are a nurse, the College of Nursing will email the certificate to you. If you are a psychologist, Knox Area Psychological Association will email the certificate to you. Social workers, LPCs, LADAC professionals, and other allied health professionals that are attending, the MHA will email those certificates to you in early December. So watch your email for those. If you are a physician, the University of Tennessee Graduate School of Medicine will actually email you an email with a link in it, and you'll have to click on that link and download your certificate from them. So it's time to get on with the show, as I like to call it. There are some things we do have to announce about disclosures. Neither the MHA or Dr. Cliff Tennyson, our fabulous symposium medical director for 24 years, have any disclosures to make. Any speakers today who have a disclosure to make, we'll have them listed in their slides. So you should be able to see what disclosures they have to make. Today's speakers with disclosures to make are Rakesh Jan, MD, Sandra Jan, PsyD, Vladimir Maletik, MD, so now let me introduce our first speaker. For our keynote session, Vladimir Maletik is a highly sought after faculty member for conferences across the country. Many in the audience will remember him as a fixture at Psych Congress. Dr. Maletik is a clinical professor of psychiatry and behavioral health sciences at the University of South Carolina Graduate School of Medicine.
Hello, my name is Vladimir Maletik. I'm a clinical professor of psychiatry and behavioral science at the University of South Carolina School of Medicine in Greenville, South Carolina. Our presentation will focus on something that has been a major issue for all of us within the last year and a half. The title is Better Together, the Importance of Social Relationships in the Treatment of Psychiatric Disorders. So let us first look at some of the neuroimmune correlates of social relationships and their relevance for major depressive disorder. I guess this may be a surprise to you that social relationships do have neuroimmune correlates. So we will start with something that is kind of an obvious and expected consequence. So there are multiple causes of systemic chronic inflammation. Some of them we have been aware all along. So if there is lack of physical activity, sedentary lifestyle, if one has a lot of fast food, processed food in one's diet, and if one is not sleeping well, we know that all that can lead to chronic inflammation. What may come as a surprise to you that being socially isolated, lonely, having a chronic social distress can also cause chronic inflammation. And chronic inflammation, aside from the risk for cardiometabolic derangements, is one of the major risks for major depressive disorder. So let us see what kind of data supports this notion. Very interesting research into potential epigenetic consequences of our lifestyle. In other words, if there's a lot of smoking, if there is a lot of pollution, alcohol usage, inadequate exercise, might this cause in utero change in how babies' genes will be expressed? And there is some indication regarding so-called exposome, that all these negative health and wellness factors actually may influence fetus at epigenetic level. So fetus will have different gene expression as a result of all these hazard factors. And it may also explain a very interesting phenomenon that has been called the mystery of American pain. It is based on a Gallup poll which was conducted relatively recently. And they compared a lifetime experience of pain in individuals who are now in their 40s and 50s versus individuals who are after their 70s. And here's the interesting part. We have already overtaken them. So individuals who are now 40 to 50 years of age have already cumulatively experienced as much pain as individuals who are older than 70 in their entire lifetime. So again, there is something about our lifestyle that is conducive to having lots more pain than it has been in the past. What might be some of the explanations? Well, again, one may have to do with deterioration of our social relationships. And we have to keep in mind that our defensive mechanisms have evolved hundreds and thousands of years ago. And if we put it into that context, to imagine one of our distant ancestors living in a cave. Being all alone in cave in the middle of the night with predators prowling around is definitely a precarious situation. And therefore, this kind of social isolation and being alone is associated with increased sympathetic response. So blood is being redistributed into brain, heart, and muscles, but increased sympathetic response may also interfere with our sleep. And frankly, if we're in such a risky scenario, it's probably not a good idea to be soundly asleep. In addition to that, there's activation of Hpa Axis, so hypothalamic pituitary adrenal activity has increased. Of course, we will need energy in case we need to respond very abruptly. So having cortisol that will recruit sugar into the blood indeed will provide such an energy source. And finally, if we are caught in a scrape where our survival depends on it, there's a good chance that our bodily integrity will be disrupted and it will have injuries. And we have to keep in mind that more human beings that have ever walked this earth have died due to infections than any other cause. So ramping up immune response would also be adapted in that scenario. Now, century and millennia have gone by. We no longer live in caves, and most of us are not isolated. Yet these defensive mechanisms that have helped our ancestors survive are still in place. And they can be activated by social circumstances, but also mitigated. So this is a very interesting little study that was conducted by Naomi Eisenberger and her colleagues. So here's what they did. There were two different conditions. One is increased inflammation, and this was artificially caused by injection of endotoxin. It would be something along, similar to diphtheria vaccine or injection of lipopolysaccharides, which are chemicals found in the membranes of gram-negative bacteria. So what happens if this peripheral inflammation is elevated due to the presence of endotoxin? Something that is really interesting, if these individuals, while being imaged, are presented with two kinds of threatening cues. One is human face of somebody who is terrified. The other one is a snake ready to strike. It is the terrified face of a person that causes twice as robust response in amygdala, part of the brain that is there to evaluate, amongst other things, threat and danger. So human face terrified, twice as much response in amygdala relative to snake that is ready to strike. What about if it's placebo? There is no inflammation. There's not much difference. So whether one presents threatening images, again, not a whole lot of response. if there is no peripheral inflammation, and especially if one presents non-threatening, a smiling face or a coffee mug. So those do not evoke strong amygdala responses. So it seems like there is an additive effect. Perception of social adversity and inflammation act together to activate our threat and danger circuitry in our brain. Interestingly enough, opposite was also true. So what if it was not a danger signal, but rather a photo of somebody who is our support figure, somebody we love? Well, if one is exposed to higher inflammation, the pleasure that we experience from looking at the face of somebody who is our support figure is also increased. As a matter of fact, there is a linear relationship. The higher the inflammation, the more activity in reward circuitries in the brain, including ventral striatum and nucleus accumbens, when we see a face of our support figure. So remember this when you're thinking about visiting a loved one, a family member in a hospital. Your presence there will create an intense joy that will, in some ways, mitigate factors associated with inflammation. So how so? Well, let us first see what the impact of adversity on inflammation may be. Very, very interesting study, included over 130 individuals. There was a risky family questionnaire utilized to assess the level of harshness in the family as they were growing up. And there were some individuals who were close to having mean level of harshness in their past, individuals who had more, 1 or 2 standard deviations more than mean, and individuals who had 1 or 2 standard deviations less than mean. If there is no stress in their life, harshness in their family will not influence their level of inflammation at all. But if there is intercurrent stress, let us say the basement has flooded, there is a divorce going on, a child is sick, there are major financial difficulties, somebody has lost a job. So there is intercurrent stress. Look how our past catches up to us. So the ones who have not had harshness in their family, so 1 or 2 standard deviations below in terms of harshness, versus the ones who have 1 or 2 standard deviations above mean, have less than a third of the elevation in inflammatory cytokines. So having these events buried in our past, combined with current stress, dramatically increases the level of inflammation here measured by production of interleukin-6, one of the major inflammatory cytokines. A few sayings from very wise individuals. So as I walked out the door towards the gate that would lead me to my freedom, I knew if I didn't leave my bitterness and hatred behind, I'd still be in prison. This was Nelson Mandela. An eye for an eye, and the whole world would be blind. This is from Khalil Gibran. And one of the secrets of a long and fruitful life is to forgive everybody, everything, every night before you go to bed, from Bernard Baruch. And resentment is like drinking poison and waiting for the other person to die, from St. Augustine. So we see no matter where individuals are from geographically and no matter what their philosophical or religious beliefs, they have all seen value in forgiveness, in getting rid of the resentment. And there's an interesting study, much more recent, as 2 years ago, that in very peculiar way confirms this. So looking at the measure of social pain, one compared individuals who have high forgiveness and low forgiveness. So starting from the placebo side, placebo in this study was 400 milligrams of potassium. So we see that individuals who had low forgiveness had higher levels of social pain. On the other hand, if there is an empty control, so that they receive nothing, it's still individuals who have low forgiveness that will experience more pain. The part that is really interesting is what happens if they receive analgesic medicine. So in this scenario, it was acetaminophen, 1,000 milligrams. And very surprisingly, if they have low forgiveness, pain medicine did nothing to relieve social pain. But if they had high forgiveness, addition of analgesic medicine actually resulted in significant reduction of social pain, indicating to us that social pain and physical pain may utilize some of the same pathways. There are further studies that support this idea. So first, looking at what is the impact of romantic love in the brain. And we see that romantic love associated with scores on passion seems to activate reward circuitry in the brain. So ventral striatum, nucleus accumbens are all very active and in proportion to the intensity of passion. But the longer the love lasts, it activates so-called default mode network, where it is being elaborated and it becomes present somewhere in the background in our mind. We think about it repeatedly. One can even say that we become ruminative the longer we're in love. So this is kind of very interesting pattern. I hate to say it, but somewhat akin to what we see in individuals who abuse substances. Again, far from it being in passionate love for a long time is harmful in any way, not at all. As a matter of fact, studies show that it may be ameliorative. And before we get to that part, let me share with you what interruption of a passionate relationship may look like. So this is a study that was conducted by National Institutes of Mental Health. And I must admit, I have a little bit of moral misgivings about some aspects of this study. How was it conducted? A number of individuals were recruited for the study. They did not know a whole lot about the details of this imaging research. One thing that they had in common, they had all been in a very passionate relationship, so above median, until within the last 3 months. And this passionate relationship ended, and it did not end of their volition. So to use an ugly word, they were dumped. Now, as they were in a scanner, they were exposed to heat pain, but there was another condition, and this condition was, much to their surprise, researchers obtained photos of the person who ended the relationship with them, and the photo of this person was flashed. Here is the part that nobody expected. Flashing an image of the person that abandoned them created the same pattern of activity in the brain, and only slightly less intense than heat-related pain. So not only was there a change in insula, part of the brain that translates sensory information into emotion, and dorsal anterior cingulate and thalamus, even sensory cortex 2, which is there to determine duration, intensity, and localization of the pain, was active in a similar fashion when they were looking at the face of the person who has just dumped them. So social pain and physical pain have almost exactly the same pattern of activity in the brain. So talking about love potentially healing pain, you see on the photo here something that's called thermode. And thermode delivers this painful stimulus. And on a scale from 0 to 100, this is around 70 in terms of intensity of the pain. The part that is intriguing is if individuals looked at the photograph of their partner, of a loved one, it significantly decreased the rating of pain. So indeed, firing of this reward circuitry can be associated with diminished experience of pain. Another study that addressed similar subject matter, women were participants in this study. There was a thermode strapped to their palm of their hand. They were, again, experiencing some pain, and there were two different situations. In one, they would put their arm through a curtain, and three different scenarios would play out. Either their partner would hold their hand, a stranger would hold their hand, or they would have a little squishy ball in their hand. And here's the outcome. Although they didn't know who it was, because again, it was a dark curtain in between, if partner had held their hand, there was decreased pain rating on visual analog scale. If this was a stranger, I guess it creeped him out a little bit because the pain scores went up. And squishy ball didn't do much to ameliorate the pain. In the other situation, those were photographs. Photographs of a partner, photographs of a stranger, and photographs of some indifferent object. And the outcome is if they saw the face of their partner, that was associated with greatest reduction in pain. A stranger and inanimate object didn't do much one way or another. So again, suggesting that having somebody who we are emotionally connected to can diminish not only our experience of pain, but frankly, even the activity in the brain that is associated with pain experience. Along those lines, social distress, how does it affect heart rate? How does it affect hypothalamic pituitary adrenal axis? So let me describe this paradigm to you. This is a Trier social stress test, and it has two components. In one component, individuals are asked to prepare a 10-minute speech, sharing with a panel of mental health experts what their future career plans are, for example. They could think about it for a few minutes, but they could not take notes. And here they are now talking about their future plans. In the meantime, this is how the panel is responding. You're talking too fast. You're talking too slow. Please organize your thoughts. You look a little bit too glib. So they're enduring about 10 minutes of this. That's not the end of it. At that point, they say, okay, let's start with 720. Start subtracting nines. 711, 702, and so forth. You're making too many mistakes, please concentrate. You're going too fast, you're rushing, take your time. You're making a mistake again. So you can imagine how stressful this could be. And that was, I hate to say it, the intent of this paradigm. So before engaging in this stress test, there were three different conditions. One is no partner. The second condition, there's a partner saying, you'll do well, I'm with you. And the third condition is partner giving them a shoulder and a neck rub. And look how that physical contact translates under duress. The ones who had physical contact had the least elevation in their heart rate during the stressful situation, and they also had the least elevation in their salivary cortisol. So indeed, what we know is that social distress indeed has these bodily manifestations where it disrupts autonomic regulation, immune regulation, and also HPA activity. And that having a partner support, especially physical support, is associated with ameliorating some of these physiological manifestations. If that is so, does hostility or positive marital interaction in any way influence cerebrovascular function or lumen of carotid artery, cerebral vasculature? And here is the finding. if there were positive marital interactions. So we're now comparing top third, the most positive interactions versus bottom third, the least positive interactions. We see that there's direct correlation with thickness of carotid artery intima media. And going in the opposite direction, having negative marital interactions. The ones who have the most negative marital interactions compared to the bottom third, the fewest negative marital interactions, had dramatic difference in thickness of carotid intima and media measured in millimeters. So I hate to say it, having bad marriages literally can clog up your carotid arteries and can end up being a risk for stroke. Again, pointing out that from the perspective of general health, it is very important to address marital issues if they are present. And something else, being in passionate love, measured by passionate love scale, seems to be associated with release in a neural growth factor. So neuroplasticity benefits also from being passionately in love. Talking about physical intimacy, this is a relatively recent publication, 2017, 3-4 years ago. And this study was conducted in women who were between ages 20 and 50. They all had at least one child, ages between 2 and 16. So researchers were curious, does sexual activity in any way influence telomere length? And this is particularly interesting because telomere length is one of the indicator of oxidative damage and premature aging. And what was an interesting finding of these studies is women who reported any sexual intimacy during the previous week had significantly longer telomeres, meaning that physical intimacy can actually, if we stretch it, protective from premature aging. Again, very interesting finding. And another study in 73 participants ages from 50 to 83 years old. About 40% were male, about 60% were female. This time they correlated sexual activity with cognitive functioning. Cognitive functioning was measured by a battery that was called ACE. ACE3 was the one that was utilized, and that is so-called Edenbrook's cognitive examination, third version. And again, very interesting finding. Weekly sexual activity was significant positive predictor of performance in this cognitive test. Is there an adverse truth? If we are lonely, can it negatively impact our brain health? So there are several studies that looked at accumulation of amyloid. We know that this is pathophysiology that seems to be associated, amongst others, with Alzheimer's dementia. And what we're finding out is that if we correlate the score on UCLA loneliness scale, we will find that the more lonely individuals have greater amyloid burden. So indeed, being lonely is not good for brain health. In another study, which, frankly, surprised me in magnitude of its effect. So this was a study that included over 1,400 individuals aged between 65 and 79. They were looking at cohabitating in two different phases of their life. So cohabitating in middle age and later on, not having a partner, either middle age or in advanced age, and having a partner in both scenarios. They also looked at so-called genetic risk for Alzheimer's, and that is apolipoprotein E4. It's a very well-known genetic factor. The part that is particularly intriguing, individuals who had a partner, both middle age, and then later on in life had such low risk of developing Alzheimer's that it negated having genetic risk factor of ApoE4. So again, if one has that factor, but is cohabitating with somebody midlife and later in life, it will almost negate the negative effect of that risk gene. Really a stunning finding from this study. So now let us look at the influence of COVID-19 on relationships. Number one, in this relatively large survey conducted in 2019, 2020. And when I say rather large, there was a sample before. So this was conducted 2017 and 18, over 5,000 participants. And during COVID, 2020, about 1,400 participants. And compared to before, during the COVID pandemic, when it comes to moderately severe, and severe depressive symptomatology, this is a US study, moderately severe, and severe symptoms of depression were increased fourfold compared to the period before COVID-19. So rather dramatic increase in depression. Now, does it matter? Does it matter how one spent the sequestration quarantine at the beginning of COVID era? And the answer is yes. So if the individuals were separated and if they did not have sexual activity during quarantine, their risk for depression was increased between 30 and 40%. So indeed suggesting that social factors such as being with a partner and having sexual activity during quarantine significantly reduce the risk of depression in those circumstances. Another large study conducted with French students. This was a 2020 publication. And here's what they found. In this cross-sectional studies, about 10%, so 1 in 10, a little bit more, had suicidal thoughts. About a quarter had a perception of high stress. About 1 in 6 experienced severe depression. About 1 in 4 experienced anxiety. Here's the part that is interesting. There were some moderating factors. So women had twice the risk. Low-level housing increased the risk about 2.5 times. Having past psychiatric conditions tripled the risk. Having symptoms consistent with COVID, interestingly enough, only increased the risk about 50%. What did have the greatest impact? Social isolation. 3.5-fold increase in risk. Gives you an idea of the magnitude of importance of these social factors. Another study, this is people aged 18 to 24. Younger folks had more problems with global impact of pandemic than individuals who were older. So it's not older people who suffer the most. That would have been a prediction. On the contrary, it's the youngest people who suffer the most. What was the increase in moderate, severe, and extremely severe anxiety? 42%. Stress was experienced at 1 in 4, and depression over 40%. This is, again, a very large sample across 3 different countries. This is UK, Pakistan, and Canada. And we see that it's very, very similar distribution in all these places. Significant. 40+% individuals experiencing anxiety and depression, and 1 in 4 experiencing stress. What were some of the important moderating factors? Family presence decreased the risk for anxiety, stress, and depression. And lack of exercise increased it. Let us now look at the impact of social adversity and disconnectedness on inflammatory factors and overall health. One of the largest meta-analyses ever. So this is analysis that involved 148 studies encompassing more than 300,000 individuals. And they looked at composite measure, including the number of social contacts and interactions and the quality of social interactions. And what it found is that composite reflecting social functioning had greater impact on mortality than stopping smoking, than having treatment of hypertension, than stopping alcohol use. It created more difference than being lean versus obese, by definition, BMI above 30. It made a more difference than having bad cholesterol. It made more difference than having treatment for chronic heart failure. So this is something that is astounding, how much social relationships can influence one's mortality, given that most of the time they're ignored. Now, we're supposed to be healthcare professionals. Unfortunately, what we are most often are disease care professionals. But if we understand this, this can actually help us be healthcare professionals, because we need to inquire about the level of social connectedness and the quality of social connectedness. As you see, this is one of the major modifiable factors of not only psychopathology, but just general health or disease state. So what if there is an unexpected and sudden loss? We're talking about general health. Might it influence inflammation? And what we see, the answer is yes. And as a matter of fact, it is proportional to the number of losses. Individuals who suffered greater number of losses had greater increase in interleukin-6. How about chronic interpersonal stress? Would that have impact on inflammation? So we're looking at individuals who have below median chronic interpersonal stress and the ones who have above median interpersonal stress, both at baseline and at follow-up. This was a study of 103 healthy young women. Mean age was 17. And what we see is that if they have chronic interpersonal stress above median, there was significant difference before or baseline and after follow-up period in terms of production of inflammatory cytokines, in this case, interleukin-6. So indeed, interpersonal stress did promote production of inflammatory cytokines, even in very young individuals. So we have looked at dyadic functioning, if you remember marriage, and impact on carotid artery. How about now just social isolation in impact on coronary arteries? Can social isolation set us up for heart attacks? Again, a fair-sized study that corrected for multiple factors, including baseline coronary artery diameter, smoking history, hypertension, high-density lipoproteins. And it looked at individuals who were socially integrated and the ones who were socially isolated, and also interaction with depression. And what we see is, even if they're socially isolated but not depressed, there was not a significant impact on the lumen of coronary arteries. But on the other hand, if somebody was socially isolated and depressed in addition to that, there was 4 or 5-fold impact on thickness of intimate media of coronary arteries. So it's really interesting that with echo and with stress test, you can actually measure interaction between social isolation and depression. So the ones who are socially isolated and depressed will have the greatest thickening of coronary arteries, both percentage-wise and measured in millimeters. And if we have followed the story so far, it is not surprising that loneliness has a strong association with heart disease in women. So looking at chronic heart disease event probability, so MI angina, what we're seeing is that women who had high loneliness over a period of 19 years had much higher percentage of having cardiac events than individuals who did not. So can social connectedness help mitigate this? Well, let's first look at emotional impact of social connectedness. It is infectious, and as you will soon see, it's bidirectional. So not only can having happy close friends impact our happiness, indeed, being directly connected to somebody who is happy increases our happiness by about 15%. Where does this come from? You remember Framingham heart study, looking at risk factors for heart disease? It's the same study. So this is 20 years worth of data. So having a happy friend increases our happiness by 15%. Here's the part that's interesting. If our happy friend also has a happy friend, his friend's happiness influences our happiness, this time increase in 10%. And even if the friend's friends had a friend who is happy, we may not even know this person, it still increases our happiness by about 6%. So being surrounded by happy people is a good thing, and it has high odds of increasing our happiness. But unfortunately, same is true for unhappiness. So each unhappy person in our circle of friends subtracts from our unhappiness by about, adds to our unhappiness by about 7%. On the other hand, being surrounded by happy people is better scenario for obvious reason, but also every happy person in our social circle increases our happiness by about 9%. So each happy person in our social circle increase of 9%, each unhappy person decrease of 7%. Is there an impact of having social supports on depression scores? Well, it is interacting with perceived stress. So if we compare bottom 25, so they are the ones who have the least social support, compared to top 25 who have the most social support. And in addition to that, have very high perceived stress. The ones who have high perceived stress and are at the bottom 25% in terms of social support will approximately have double depression scored measured by Center for Epidemiologic Study of Depression scale. So again, lacking social support in combination with perceived stress, this is a toxic combination that dramatically increases depression scores. Obviously very clinically important, because when we're face to face with the depressed patients, this is something we can easily ask about. Rather than piling on the medicine, let's inquire a little bit about their social support. Let's inquire a little bit about their perception of stress in their life, because this can be very influential in terms of the severity of their depressive symptomatology. And indeed, we're also finding endocrine correlates. So the less social support there is, the more reactive stress system in Hpa axis will be, the higher levels of cortisol. It goes further. Having 4 or 5 social ties reduces the risk of metabolic disturbances. So individuals who have 4 to 5 social ties have dramatically fewer incidents of high blood pressure, and they have lower waist circumference. There is also a marginal impact on hemoglobin A1C. So even their glycemic control is better if they have 4 to 5 social ties. It's interesting, we don't think about social ties as having that kind of somatic impact. We do think about its impact on psychological well-being, but as you can see, it's also physical health. A long follow-up, 9-year follow-up in Alameda County study. The answer was, over this 9-year follow-up, did social connectedness help individuals live longer? So 4 categories: the least socially connected, and then the 4th is the most. And what we're finding out, both in men and women, the ones who were most socially connected had death rate that is less than half of individuals who were the least socially connected. So having good social connections literally can extend your life. Something to think about. And is there any way to mitigate it, especially in an individual who is 70 to 85? Volunteering significantly reduced an indicator of inflammation. This is C-reactive protein. So being out there, helping other human beings who are less fortunate can actually help us reduce our inflammation. Again, this is a National Social Life Health and Aging project that included over 1,700 individuals. So let us look at relevance of evaluating social factors and addressing social factors when it comes to treatment of major psychiatric conditions. We are now looking at one of the more progressive guidelines. So this publication by Jen Mali and colleagues, reflecting the newest edition of Royal Australia New Zealand Guidelines for Treatment of Depression. A couple of interesting points. One is that they have recognized social factors as being important in etiology, origin of major depressive disorder. And they have also found that having social problems is an actionable item when it comes to treatment of major depressive disorder. Therefore, lining up some social supports really needs to be a part of our treatment plan for any individual who may be suffering from major depressive disorder. Another a large study, this is over 100,000 participants in a UK biobank study. The study examined the impact of 106 modifiable factors on the prevention of depression. So here's again, we're talking actually about healthcare, preventing depression. And what has been noted is that frequency of confiding in others. This is frequency of confiding in people who have a meaningful role in our life, who are trustworthy, who are close to us. I'm not referring to getting drunk on Friday night and going to the bar and spilling one's guts. That really would not help a whole lot. But again, confiding in trusted individuals, people who have an important role in our lives, very, very important modifiable factor in prevention of depression, as would be visits with family and friends along with exercise. So something, again, that ought to be part of our treatment plan. Now, do we sometimes neglect the impact of social adversity when it comes to treatment outcomes of major depressive disorder? So we're looking at remission rates in individuals who received an SSRI plus supportive care or just supportive care. The outcomes are very similar. If they have significant social adversity versus the ones who do not have social adversity, their remission rates will be reduced by half So many times when the medicine is not working, we're immediately thinking, should we augment or switch? The first thought that crosses our mind would be, is this individual exposed to social adversity? Because it can cut remission rates in half. This is social adversity. How about dyadic discord? Marital adjustment scale was used to measure dyadic discord. The group was divided in two halves, the ones who were above median and below median. Investigators were interested in finding out if dyadic discord will influence remission rates in individuals treated with an antidepressant, in this case nafazidone, cognitive therapy, or combination. Well, the first finding is that combination worked better than antidepressant or cognitive therapy. But the part that is really intriguing, if individuals had dyadic discord, their remission rates in response to antidepressant and cognitive therapy will be cut in half. So again, antidepressants often work for treatment of major depression. Antidepressants are suboptimal treatment for bad marriages. And we do need to think about the quality of marriage or dyadic relationship as well as social adversity, because they will have a significant impact on how our patients are going to respond, be it to psychotherapy or to medications. As a matter of fact, another study that examined the impact of social support on prognosis of treatment of major depressive disorder found that individuals who have adequate social support had substantially better outcomes 3 to 4 months later. The ones who had inadequate social support had 32% less chance of achieving remission 3 to 4 months later. So, social support, social adversity, quality of dyadic relationship all have very substantial impact on response to antidepressant treatments. If this is so, and especially if there is a problem in dyadic relationship, might marital therapy help depression? The part that is intriguing here is that it involved 36 couples and no medicines were used in this study. There was a degree of marital disturbance in all of these scenarios. Women were identified as patients in this particular study. And what was noted is that marital therapy, when there are problems in marriage, yielded significant reduction in depression score, much more so than even individual therapy at follow-up. So again, a meaningful therapeutic intervention which needs to be part of the treatment plan if indeed there's a problem with dyadic functioning. And then looking at the impact of CBT. So this is cognitive behavioral therapy. We see that psychotherapy can help with improvement in depressive symptoms. The question is, can it help with some of these somatic correlates of disturbed relationship? And two things that we're finding out. Number one, the higher the remission rate and the greater the reduction in depression score, the less inflammation will there be. So that is good news. And the other thing is, if we compare inflammatory cytokine, in this case, interleukin-6, pre and after CBT treatment, we're seeing that 7 sessions of CBT significantly reduce inflammatory signaling, again, as measured as interleukin-6 levels. An intriguing question. Does type of pharmacotherapy influence the likelihood of improvement in social functioning? And here's what we're finding. If we compare individuals who have been treated with norepinephrine reuptake inhibiting agent, in this case it was reboxetine, this is an agent that is not available in the US market, versus an SSRI, it's a paroxetine, or placebo, we are by far seeing greatest improvement in social adaptation self-evaluation scale, or SAS, if norepinephrine boosting agent was utilized. And in terms of remission rates, we see that if norepinephrine agent was utilized and in individuals who had improvement in social functioning, it was associated with about 5-fold likelihood of remission. So having improvement in social functioning associated with norepinephrine reuptake inhibiting agent treatment provides much greater likelihood of achieving remission. Now, is there any room for so-called precision treatment? And is there a category of depressed patients where using a noradrenergic agent may be more beneficial? So in this particular study, published about a decade ago, they compared norepinephrine and serotonin modulating medication, which is in this case milnacipran, with serotonin reuptake inhibiting medicine, which was paroxetine. And while in individuals who had low psychomotor retardation scores, this is item 8 on Hamilton Depression Rating Scales, there didn't seem to be a big difference in terms of response rate on CGI between SNRI and SSRI. But individuals who did have the highest scores on retardation scales had almost double the responses on serotonin norepinephrine reuptake inhibiting agent versus SSRI. So high scores on psychomotor retardation item 8 on Hamilton Depression Scale is associated with preferential response to serotonin norepinephrine reuptake inhibiting agent versus an SSRI. The other part that was maybe not anticipated, along with improvement in depression scores in individuals, one also noted significant improvement in social functioning on SAS. So if they have psychomotor retardation, not only will they have greater benefit in SNRI versus SSRI, but there will be also improvement in social functioning. So how do we begin to address some of these social dysfunctions, loneliness, trouble in dyadic relationship? How do we begin to address it in our patients? Well, we do the same thing that we do with any medical condition, and that is start with diagnosis. So where are these individuals in terms of their social functioning? Is this a primary vulnerability? So their important relationships are at risk. Secondary, have they started being disconnected? Or is it tertiary? Are they already socially isolated? So again, we need to address severity of their social distress, of social impairment. And then once we know what the severity is, we can think about levels of treatment. So there are some treatments which are in individual level. So one can do CBT that will focus on social relationships, that will focus on distorted pattern of thinking regarding how one is perceived by others and how one perceives oneself in social circumstances. One can provide social skills training, but there can be also interventions that will involve social grouping, primarily family and friends. There are things that they will be able to do, and we'll review these in just a few minutes. And finally, if we really want to be activists in our communities, there are certain things that can be done at societal level. There can be regulations which will promote better socialization and reduce the likelihood of social isolation and distancing. So there are multiple levels at which we can intervene. I mentioned cognitive therapy, focusing on changing social cognitions. Many of these individuals have misattribution, where they perceive others as being disinclined towards them, disliking them, ignoring them, There's a lot of negative perception in social setting. At the same time, they see themselves as being uninteresting and unappealing. And these faulty cognitions need to be addressed in context of cognitive therapy. Then there is cognitive skills training, getting better at reading nonverbal cues, body language. This can be improved quite a bit with some investment in therapy. And then there are these group interventions, such as supported socialization. Individual does not feel ready to go into a social setting. They do not feel ready to mingle. What may help is if they have close friend or relative saying, why don't you come with me to this event? I will help you deal with it. If you feel anxious, we can always leave, but let's go. And this individual, with a little bit of instruction, can help dissipate anxiety and can help address some of those distortions. Altogether, providing for a better experience and having history of these better experiences then builds on itself. There's a greater likelihood that this individual will continue to socially engage. And then there are wider community groups, getting involved in gardening club, getting involved in group hiking activities, in group biking activities. There's so many social activities going in every town from mid-size up in the United States. One can encourage participation in these groups because there are a lot of other people there who will be lonely and they can help each other. So again, there are many, many interventions. But what are some of the key takeaways from this study? Early life and relationship history should be critical components of any mental health interview. Family therapy and addressing inadequate social supports may not only help alleviate psychiatric symptoms, but actually may help with bodily manifestations and improve overall health. It is a good idea if we have adults who are also parents to encourage positive parental behaviors, or if you have concern about their ability to parent, even refer them to parenting-focused family therapy. Marital therapy may be a significant factor in improving depressive symptoms and improving dyadic relationships. Improving dyadic relationship not only is likely to help with remission rates in depression, as we can see, it can double it, but it can also improve metabolic, neurobiological functioning, inflammatory signaling. And efforts need to be made not only to diagnose our patients' social misadventures and isolation and loneliness, but also to help them learn skills to cope with this, address these faulty cognitions, and do everything to support them to re-engage in social relationships. In summary, early life adversity and troubled social relationship may contribute to autonomic, endocrine, and immune disturbances. Early life adversity and problematic relationships may compromise general medical health and actually reduce life expectancy, as well as interfere with successful treatment of depression. There are therapeutic strategies both to diagnose and treat some of the social dysfunction, and full understanding that improving socialization in our patients may be a key component of treatment, not only of MDD, but other psychiatric conditions. And with that, I will thank you in your kind attention and conclude this presentation. Thank you very much.
Well, Vladimir, it's always good to see you again. Thank you very much. That was wonderful.
Thank you, Ben. Yeah, it was a pleasure. And I appreciate being invited again to participate in this meeting.
Yeah. So I have a first question to ask you, and then I'm going to turn to Cliff while I try to harvest a few questions from the chat box. So in this whole conversation of
relationships being better and helping people in their recovery. What about peer relationships with a peer specialist?
Could you please define when you say peer specialist?
Well, certified peer specialists have been recruited, hired, and trained to be placed in multiple clinical settings and programmatic settings across the country, whether they work in hospitals or they work at mental health centers or with other agencies. Their involvement with persons involved in treatment can be an essential part of their recovery.
Yes, I would agree with that. Having anybody who would be a peer specialist, having anybody who's a life coach would definitely enhance outcomes. I think that the studies have looked at totality, so they have looked at frequency of social interactions, and they've also looked at quality and depth of social interactions. And I think that the conclusion is that totality and depth of social interactions are both influential in terms of outcomes. When I'm saying quality, I would say that also that I've seen a couple of questions regarding virtual connectivity, and I think it is very important. I don't think it's a complete replacement for face-to-face communication, but it is definitely helpful. And then frankly, how beneficial social interactions are really depends on the quality of interaction. Because there are also studies that very superficial communication can actually be detrimental when it comes to health outcomes. And if one has interaction with that is negative in nature with friends, that can actually cause deterioration. So it is good to have good communication, and we can't be selective and choose to socialize only with happy, optimistic people, but there definitely needs to be a balance.
Okay, I'm going to ask one more question, and then I'm going to let Cliff take over for a few. So the first question in the box was, how was forgiveness measured?
They actually had scales that they utilized to measure forgiveness. So it was a validated scale that was used to measure forgiveness.
Okay. All right, well, I'm hoping that I can be heard right now.
Yes.
Okay. There were 2 or 3 questions that were kind of expected, actually, with regard to this topic, that have to do with COVID and that have to do with social isolation secondary to wanting to protect oneself. One question was about elderly people who are really at high risk, and are there ways that we can help them increase their social interactions? Another question was on the opposite end, children and adolescents who, even before COVID, were using more virtual, online, non-in-person strategies for getting some attachment to and some activity with their peers. And then the third one was, do we have some suggestion that even virtual support online can be beneficial? Or are there studies that show the difference between in-person and virtual for any of these populations?
Excellent question. Well, there are several comments indeed. With elderly, there are community outreach programs that were attempting to establish communication. Another problem in that scenario related to COVID-19 is that one needed to be relatively proficient with using media, and many elderly individuals were not most equipped to use either smartphones or laptops, and that really increased the concerns. And but there were agencies in many states that provided cell phones, so at least cell phone contact could be established with their friends or family members or mental health providers. Now, the part that is really interesting, loneliness, social isolation during COVID-19 did impact elderly, but they actually fared much better as an age category. Individuals who had the greatest problems were individuals between ages 20 and 30. And it's interesting because there's social isolation as an objective phenomenon, and then there's a sense of loneliness that is subjective. So all the detrimental effects were actually mediated more by subjective experience of loneliness than by social isolation. So it depends on how one handles quarantine. And another part that is interesting, yes, having communication with the therapy community, having communication with friends and family members was good. But on the other hand, in early phases of COVID, it was actually very detrimental, and it resulted in increased depression scores. Why? Just think about it. All they were hearing is, there's this virus out, it's deadly, we don't know what to stop it. And oh, by the way, we're all running out of toilet paper. So when social media were used to disperse negative information and fear, that spread like wildfire and actually contributed to significant drop in the quality of mood. When it comes to youngsters, one can look at it in two ways. On one hand, there's information that playing many games, especially if there are multiple players online at the same time, it may actually help increase and improve social skills. But on the other hand, there are also studies showing that total screen time is a risk factor for anxiety and depressive disorders. So I would say there's probably an inverted U curve. There is optimum, and in some situations, it can be beneficial. But if excessive, and if it is done at the expense of having better relationships with family members and peers face to face, it can also be detrimental.
Thank you.
Thank you.
Another important question that comes up is with regard to, we see a lot of the data with regard to social relationships being protective.
Yes.
And then there's others that show that there can be continued, there can be a result from people who are already suffering, who already have some kind of neuronal or tissue injury with pain or depression or whatever.
Mm-hmm.
And those are two separate ways to look at, to do research. Is there research that does before and after that you have seen? In other words, can we prove that supportive relationships, forgiveness, romantic love, etc., is healing already damaged neurons or other tissues in the body?
Unfortunately not. So it would require a large-scale prospective study, because I imagine effect sizes would not be great. But no, there is no evidence that if the damage has occurred, one can reverse it. Most of the studies that are longitudinal are observational studies, and they have cross-sectional way of compiling data. So it is association. There is no way to establish causation. Okay. So at this time it happened, at this time it happened, hence there is a strong association. But again, there is no claim to causation in any of those, and there is no claim that one can reverse any kind of neurological damage, structural functional change in the brains of individuals who already have neuropsychiatric conditions.
Right. So we need to be careful about clinicians telling clients and patients that their injuries can be healed. We do know that there's neuronal regeneration in a lot of various studies, but that's a different subject altogether.
It is. And even then, frankly, it's very limited in terms of human brains and capacity to regenerate. There is a little bit of capacity in hippocampus and olfactory area, and that's about it. Prefrontal cortex, GABA interneurons can regenerate, but regenerative capacity is less than 5%. So human brains in general, mature adult human brains have a very, very low regenerative capacity when it comes to nerve cells, that is.
So we need to focus on
Preserving.
Let's move forward from where you are right now.
Indeed.
Absolutely.
Health practices preserving rather than having a very slim hope in regenerating, indeed.
Well, here was a really interesting, very focused question about the sexual intimacy studies. Was the effect of sexual intimacy measured quantitatively? In other words, did benefit increase with increased activity?
It's a very intriguing question. No, it was the study in elderly did it happen last week? That's all. So was there one contact, that sexual contact? That would be about it. So there is really, to my knowledge, no quantifiable way saying that such and such sexual frequency of sexual intimacy or quality of sexual intimacy directly has neurobiological benefits. So the part that is intriguing, again, this is an association. So you may say that people who are in better mood and more neurologically intact are more likely and have more vigor, are more likely to engage in sexual activity, right? And then association would still be true. So we can't imply causation, but there is definitely association between sexual intimacy and overall mental health.
Lot of emphasis on I loved the fact, and so did some people who gave their comments about the quotes that you showed. So even ancient wisdom, prior to the scientific method, people have noticed this for thousands of years. Let me turn something over to Ben. One person asked about a mental health association program, Mental Health 101. Can you explain that really briefly and ask Dr. Maletik whether or not we have data to support that particular effort in our community?
Yeah. So Mental Health 101 is a school-based outreach program. We teach middle school and high school age students what symptoms of mental illness to recognize, what symptoms of suicidal behaviors to recognize, the appropriate duration of those circumstances that they need to act on to be able to intervene and get help for themselves, a family member, or a friend. And the ripple effect is profound. You know, we used to teach when we first started at 2 schools, and now we teach at more than 100 schools annually across all of East Tennessee, and can teach upwards of 30,000 kids. And what that has done is it's caused a very interesting increase in youth entering treatment, because kids are getting identified earlier and they're reaching out for help earlier instead of experiencing a decade or longer of treatment delay.
It's a wonderful project, and here's what I can say. Depression with onset at earlier age, so we're talking a pre-adolescent or adolescent onset, typically tends to be more recurrent, more chronic, more difficult to treat. The other part that is also important is depression prior to age 18, 2 to 1 is associated with subsequent bipolar disorder. So I think it's good to recognize it. It's good at that point to have a more detailed diagnostic evaluation in order to determine if this depressive episode belongs to major depressive disorder or bipolar disorder. But be it as it may, there are longitudinal studies that have looked at delay of treatment. And it was very simplistic design. They looked at individuals who received treatment within 12 months of the onset of condition versus longer than 12 months. If it was longer than 12 months with an onset of condition, rate of hospitalization, rate of recurrence, and rate of suicide attempt was double.
Yeah.
So indeed, having an early recognition and early intervention literally can be life-saving. So I think it's a wonderful effort.
Well, it was one of those moments back in the day when we thought we need to do this, and we couldn't get into schools until we kept working at it. And finally, when we did get in, then it became sort of a tidal wave of schools asking us to go to their schools and teach their kids. And so we're trying to grow that program now. So thank you. Cliff, I'm going to give you one more question before I've got to wrap us up.
Okay, one more very focused one. One of our attendees asked specifically about the slide on marital therapy.
Okay.
When people present for difficulties in their marriage. And the question is, I mean, we can assume what the answer is, but we want to hear from you. Would the same treatments and interventions listed in the study for loneliness also apply to a couple who comes in, still a couple, but they're coming in for marital discord?
So it's very interesting. I would say that it would be important, right? So if they are there and they have identified patient and identified issues, and also some degree of marital dysfunction, I think that dyadic, I think couples therapy would definitely be beneficial. But in addition to that, either one or both of them may also be lonely. And at that point, I think it's a good idea to measure loneliness. So what I would suggest to our community this morning is to avail themselves of a free download. And it is UCLA Loneliness Scale. Again, it's a free download. Use it and diagnose loneliness. And then once we have diagnosis and we know the stage of loneliness, is this something that is incipient? Is this something that has already happened? At that point, we can also talk about interventions. Would they want to socialize together or separately? Cognitive behavioral therapy individual focused on addressing some issues. Is there a lack of social skills? Do they have dysfunctional perceptions about themselves that interfere with their social interactions? Would they need some help? Would they need a family member or another couple that will bring them into fold, so to say, and to increase their social interactions? Will they need some volunteer activity? There are many, many ways. But again, dealing with loneliness, like with any other mental health problem, starts with diagnosis.
And we also, many of us who are mindfulness trainers in our therapy are probably thrilled with the information that you gave, especially about happiness being infectious. So
Indeed.
thank you for that.